Okay, good afternoon. My name is Nicole Magruder, and I'm the Executive Director of Community Hero Action Group. Our mission is closing the gaps in health and wealth disparities within the Black community. And I am here for another session with the 2022 Pennsylvania Black Health Matters Conference, Disrupt and Build Up. Our next session we have with I should say, Dr. Monique Gary, and she's going to talk to us a little bit more about developing trust with your physician. And especially with your cancer care. She is an oncologist, so she is very well versed in this area. And she's going to speak a little bit more about her and go into the presentation. If you have any questions, please be sure to pop them in the chat. If you're watching on social media, you can still submit questions. However, you won't be able to earn any points unless you actually register for today's conference at blackhealthmatterspa.org. This session is being recorded and all sessions are being uploaded so you can watch them on demand throughout the week. And if you don't make it back to the conference, it will be available on our on our YouTube channel, which will be launching next week. All right. Thanks so much. And I hope that you enjoy this upcoming session. All right. I will hand it over to you, Dr. Gary.
Well, good afternoon, and thank you for inviting me to be a part of this conference and to give this particular talk because this subject is very near and dear to my heart. When we talk about the historical basis for, I'm going to call it earned medical mistrust, right? Why is it that we have some issues in our community with trusting physicians? And how does that then translate into the care that we receive, the good care we receive, the bad care we receive? And how do you get more juice for the squeeze from your interactions with your doctor? And so those are all the things that I kind of want to talk about today. And we're going to circle back and talk about a type of breast cancer that particularly impacts Black and brown women in disproportionate numbers, which is triple negative breast cancer. But first, let me tell you a little bit about myself. My name is Monique Gary. I am a Philadelphia native, born and raised, not on a playground. I did not spend my days there, but I graduated from the Philadelphia High School for Girls and went on to Florida A&M University, where I received my bachelor's degree and came back to Philadelphia to receive a master's degree in molecular biology in conjunction with PCOM and Fox Chase Cancer Center. And then went to medical school, 5 years of residency in Massachusetts at UMass and a year of fellowship at Georgetown University Hospital in breast surgical oncology. So I'm a breast cancer surgeon, and I direct the cancer program at Grandview Health in Sellersville, Pennsylvania. It's about an hour outside of Philadelphia. And how did I end up here? Well, there was a need and an opportunity to build a program for a group of folks who had no breast surgeon in the area and really had no trust and faith in their medical providers to provide good cancer care. And so that is why I'm here. And I, of course, continue to do outreach in Philadelphia. I'm on the medical advisory board of Living Beyond Breast Cancer, Touch, the Black Breast Cancer Alliance, Tiger Lily Foundation, the Chrysalis Initiative, and many others. And so you'll see me around. You'll hear me on 105.3 sometimes and 107 with my girl Lady B doing the check-in with Dr. Mo. And so again, just thank you for allowing me to be here. So I'm going to share my screen and some slides. I don't have a whole lot, but there's a couple things that we should definitely talk about. Let's see. Are you able to see my PowerPoint? I'm going to continue as if you are. If you are not, please let me know that you cannot see the PowerPoint presentation. But again, on our side, we're going to talk about building trust with your doctor, especially as it relates to cancer care. This is where I practice. Again, it's Grandview Health. We're part of the Penn Cancer Network, and we're about an hour outside of Philly, where I direct the cancer program, I direct the breast program, and chair the research committee. So about a year ago, I was very fortunate to be invited to participate in a consortium through a pharmaceutical company called Novartis. And Novartis said, we want to tackle the issue of breast cancer for Black women, and we want it to be about more than just words. We want to give women tools to be able to address some of these disparities. And so they approached myself. They approached another Philadelphia native you might know, Grammy Award winning singer, Philadelphia homegrown singer, Jasmine Sullivan, Ricky Fairley, who is the CEO of Touch, the Black Breast Cancer Alliance, and another Philadelphia native, Jamil Rivers, who heads up an organization called the Chrysalis Initiative for Black women facing metastatic breast cancer. And they said, we want you to put your heads together and let's come up with a tool to help people talk to their doctors. Because when you get into that office, you know how it is. I know how it is. You had a list of things that you thought you wanted to ask about. You kind of knew what your symptoms were. And then the doctor starts talking. And you're like, okay. And then they do the exam. And next thing you know, their hands on the doorknob and they're out the door. And you're like, oh wait, I didn't get a chance to ask. What was I going to ask? And you didn't get that chance to have a rich conversation. And you go home and your family members are like, well, what did the doctor say? You're like, I don't know. And that to me is unacceptable. If a patient leaves my office and they have no idea what I said and what we talked about, then I have failed as a clinician. And so I wanted people to have a toolkit to talk to your doctors so that you can understand what's going on. Okay, so talking to your doctor, it can be scary. And we know that when the statistics surrounding breast cancer for Black women, we're almost 40% more likely to die of our disease. We are more likely to be diagnosed at a younger age with later stage disease. But it's hard to find doctors who look like us. Representation matters, and only about 2% of practicing oncologists are Black. That includes men and women in the breast cancer space, especially for surgeons, even less than that. We're fortunate in the Philadelphia area to have at least 3 Black women surgeons who deal with breast cancer in the Philadelphia area. And we're all in the Penn Cancer Network. And again, we're very, very glad for that. But for a number of years, there was only just one out here in horse and buggy country. And so your doctor might not look like you. And how do you then be sure that you're getting good care? So you want to establish trust, because at a time when you get this diagnosis, let's start from the biopsy, from the abnormal imaging. Maybe you just went in for your screening mammogram and then you get a call back. And now you go back and you get more imaging. And then you're told you need a biopsy. All the while, the anxiety is building. The uncertainty begins to build. And now you're starting to say, okay, well, where should I go to get my care? What's going to happen with the kids? What about summer vacation? What about my job? What about, my savings? And so all these things are swirling in your head. And by the time you get to that office visit to talk to a doctor about, your diagnosis, there's a whole lot of other stuff in the room with you. And it's hard to hear what's going on. And so there's some key bullet points here on the bottom of this screen that talk about how do you really have this relationship. And the first thing you want to do is you want to have an active role. Ask questions. I never, ever am offended by patients who ask questions. When you come with your questions written down, I think we have a better conversation. Be an active listener, so mirroring or repeating back what you heard. And I always will start with, well, what do you understand about what's going on? And let you talk first, and you tell me where you are. And then if it's right, if it's wrong, if there's questions, we can fill that in. But I want you to be thinking about what you understand. And then before you leave, I'm going to ask you again. So what will you tell your family when you leave? But that active listening means, Doc, I didn't quite get that. So what I heard you say was this, and this. Is that right? And you make that doctor pause and mirror back to you whatever that information is. Too often we do this and we're not really getting it. And we may not be writing it down, or we may be writing furiously and we may miss it. That doctor speaks fast. They may use words that are really, jargon, we call it. Medical jargon is stuff that you wouldn't understand. It's not in your vocabulary every day. You should ask your doctor for resources to review after the appointment. What can you take with you that you can look at later that helps you remember this conversation and what's going on? And then the last thing, invite your doctor to view things from your perspective. One of the most powerful questions you can ask a physician is, well, doc, what would you do if you were sitting in this seat? What would you do if I were your mother, your daughter, your partner, your spouse, your wife? What would you do? How would you manage this? Would the conversation be any different? And it forces a physician to see the humanity in front of them and not just the chart, not just the next room. We go room to room to room throughout the clinic, right? 30 patients a day sometimes. And it forces them to see you. And that's a really important thing. So, what happens if you're just going in for screening? You're going in to, get your annual breast exam, and somebody told you, yep, you got dense breasts, and okay, you have fibrocystic breasts. Maybe you should go see the doctor. There's some things that you should go over. There's like 5 musts that you should have at any breast health appointment, but really any primary care appointment. There's 5 key things that you kind of want to look for. And the first thing is there should be a discussion about your family history. We as a community, as a Black community, and I'll tell you firsthand from my own family, there's a couple things we don't like to talk about. We don't like to talk about money. We don't like to talk about health. And those are 2 things that we need to talk about the most. So there needs to be a discussion about the family history, because you know what happens. It's like, yeah, Nana had the sugars, or she had something down there, and then we didn't get it. But it impacts not only your risk for getting cancer, it impacts the type of screening that you should get, because when there's more relatives with a certain type of cancer, you should get screened at a younger age. You might be eligible for things like MRIs and ultrasounds and additional screening. But if you don't know that history, you won't know what your actual risk is. So that's a big part of knowing your risk. And just like when we go to our family reunions, we like to talk about, Uncle so-and-so married Aunt so-and-so, and then they had these kids, and we got the whole tree mapped out. We didn't go on an ancestry. We are getting really skillful at tracing our lineage and our ancestry. But we need to be just as vigilant to trace our family history. Cousin Cecil had colon cancer, CRC, colorectal cancer. Uncle Joey had prostate cancer, PC. He was 57. Put it on the tree. It's nothing to be ashamed of, but everybody needs to know what's going on in the family for the health of the family. 2, you should have a thorough exam. If you're coming to see a breast surgeon, they should be doing an exam, and they shouldn't just go, yeah, got dense breasts, see you later. What does that even mean? Do you know? They should tell you. They should tell you where your lymph nodes are, so that when you go home and do an exam, you can say, okay, Dr. So-and-so said my lymph nodes are under here and I should feel here. Dr. So-and-so said I have dense breasts over here, and they should be the same. And so I actually point out with my patients what the breast exam is. Where do I feel lumps? What does normal feel like for them? Because when you leave, your job is to check for normal. And we teach this wrong. And that's why we stop telling people to do the breast exam, because we say, check for lumps, check for lumps. Check for normal. Learn what your normal feels like, and it should feel the same every month. But a doctor should be reviewing that with you. 3, ordering some type of test or scan or image. Is it a must have? Well, if you have a complaint, then yes, there should be some follow up on that. Any doctor who says, oh, it's probably just cysts. Did they have x-ray vision? Did they do an ultrasound in the office, perhaps? If they did, then that instills confidence. But if they're assuming something without working that up, that's when the red flag goes off. And that's when the finger goes up, like the finger, that church finger goes up. And you say, well, doc, how can we be sure? Is there something we can do to check that? And you don't let a doctor dismiss you because of your age. We are trained to look at patterns. And the patterns say that young women get cysts and older women get cancer. But what if I told you that young Black women under the age of 35, are one of the fastest growing demographics for breast cancer, right? And so that means when you go to your doctor with a lump, they can't afford to blow you off. They cannot afford to say, oh, it's probably just this. It costs them nothing to order that scan, to do that ultrasound, to work it up further. And so that's something you should be looking for. Now, if it's your annual, you may not have any imaging at your annual appointment. But if you're over the age of 40 and you're at that screening mammogram age, then yes, your doctor should be giving you a script for a mammogram. And it should, in general, be a 3D mammogram. 3D mammograms are different than 2D. The machine moves in 9 slices through the breast. So when you put your breast in that machine, it used to just go x-ray, x-ray. Now the machine moves forwards and backwards and side to side, and we get an actual movie of the breast so that we can see through the density, because Black women have on average 30% higher breast density than white women. And what does that mean? Well, the density It's like, oh boy, I'm old. So I use the analogy of a console TV. Remember those big floor model TVs? My grandmother had one. The static on the TV is the density. The more density you have, the more static on your screen, the harder it is to see the picture. So the more density you have, it's not the feel, it's the actual how thick is your breast on the mammogram. The thicker your breast is, the harder it is to see the cancer because you got all the dense breast tissue, all the static on the TV screen that's blocking the picture. So 3D mammograms are like the difference between big old console TVs and flat screen TVs, LCDs, plasma, right? Picture quality is much better. So black women should be getting 3D mammograms. Time for Q&A. If that doc's got their hand on the door and they're walking out the door, you say, hey, doc, you got a few seconds for questions and answers? Can I talk to you? Can I talk to your nurse? Can I get my questions that I wrote down beforehand? Can I get these answered? And if that doctor says no, then you got a problem. And you may want to talk to the nurse. You may want to remind that doctor that it's important for you to get your questions answered, or you may want to get a second opinion or find a new physician because any doctor doesn't have time to answer your questions. It's a value statement and it's a really important thing to do. You should always have time for questions. The last thing you want to make sure before you leave that office, because you know how it is, doc says, okay, put your clothes on. We'll see you in 6 months. What's the follow-up plan? So I felt the lump over here. We're going to get an ultrasound. What should I be checking for? Or I had my imaging. It didn't show anything, doc. Everything looks good. Is there something I should be watching out for in the next 6 months, in the next year? When should I call you back? When do we check this again? If we don't need to check this again, then what are some warning signs, things to watch out for? So you should leave knowing what your steps are. When I go, I'm going to do my exam every month. I'm going to follow up in 6 months. I need an ultrasound and a mammogram. You should have a plan. You should not leave that doctor's office and just say, I don't know, I guess I'll be back in 6 months and not know. Okay. Now, I think it's important for us to talk about some uncomfortable things because doctors use a different language than the average person. We're actually trained to unlearn the regular English, and we use words like obese, right? We use words like BMI. We kind of have some descriptors in the chart, and now patients have access to their chart. So you might read your office note, and it may have codes on there that you didn't know and that you don't understand. But it's important for doctors to talk to you about your breasts, the density of it, to talk about weight. Weight not as a method or a tool for shaming, but for you to understand your risk for certain things. So the term obese or overweight is a diagnosis. It's not a judgment against the patient. And your doctor may say, where are we with weight loss? And that's an important conversation. But if you see the word overweight or obese, that's just a clinical diagnosis that they put based on the BMI, based on the weight. Now, whether or not BMI is a fair assessment for Black people, we'll talk about that some other time. But if you see that on your chart, you should not necessarily be offended by that because the majority of people, especially Black people, by the way BMI is calculated, may actually be overweight. That being said, when we can reduce our weight, our actual pounds, by 10%, you can drop your risk for breast cancer. And so that's why it's an important conversation, whatever your weight is, because being overweight is a risk factor for breast cancer. Being sedentary is a risk factor for breast cancer. So you should be exercising about 30 minutes a day, 5 days a week. Don't tell me you can't do it. You don't need a gym membership to do it. You can watch 1 hour of TV with commercials. No Hulu, no Netflix. Don't skip the commercials. And if you exercise during those commercial breaks, and if you can build up to exercising for the complete commercial break, you will have gotten in 1 hour TV, almost 20 minutes of exercise without leaving your couch, without leaving your living room. So it can be done. But if you're 200 pounds and you can lose 20 pounds, guess what? You can drop your risk for breast cancer 10, 12%. And that's huge. Family history. The doctor's not trying to be all up in your business, They want to know because they want to be able to tell you what your risk is for you getting what runs in your family. And that means that you have to ask your family as well what runs in the family. I heard you say Nana had something down there, or she went to the hospital, or she had a surgery, or Grandma, what's that scar? Or Mom, how come blah, blah, blah? you know? And it's a hard conversation for us to have in our families, but it is a really, really important conversation. And you can always center your family member's strength, their spirituality, their faith, and they can tell you about a time when their faith was really challenged. And it might center around a health crisis or a health diagnosis. Now, what if you think you're getting biased care, right? Like, did that doctor just say, did I just hear? I felt like that might be racist, right? So, what if you hear that? What if that happens? If it happens, I think the most important thing that you can do, one, if you feel confident, you can say, hey, doc, did I hear you say this? Or what do you mean by that? Right? That's a powerful tool. You put it back on them. What's that mean? And ask them about it. If you say, I have 4 kids, and the doctor says, well, how many baby daddies? Excuse me? What do you mean by that? And it forces them to retreat and to explain. But if you feel like you're getting biased care, you need to talk to someone that you trust, and you need to trust your gut and maybe get a second opinion. But before you walk away, because we don't always see eye to eye with our doctors at first. And I get it. I as a patient, as a family member of folks who have had cancer and sitting in that seat of the loved one, taking notes and writing things down, you don't always see eye to eye. And so there's some things that you can say. And over here on the right side of the screen, can you show me where this is in the guidelines, or are there some guidelines for how we treat this diagnosis? Can you show them to me? And then you can see, is what they said part of the guideline or not? You can ask that question. What makes you say that? Or, wow, I didn't expect to hear that. I wasn't expecting you to say this. And then let them explain. Okay? So it's a really important thing. And what it does is that is what builds trust, is that you are able to have these candid, really vulnerable conversations with your doctor, because your doctor might not have even realized that they said something or that they skipped over something in their head, and that what they were saying seemed biased, in fact, when it was really just part of the questions they needed to ask you or a conversation they needed to have. You might have heard, something like, well, and in the event that you need chemotherapy, blah, blah, blah. And you're like, wait, what? I didn't expect that. Did you say I'm going to need chemotherapy? Where's that in the guidelines? Can you show me? And they should be able to show you. On the subject of needing more time, the time is the one thing everybody can't get back, right? It's the most valuable asset we have, is how we spend our time. And, I recognize the privilege of patients coming to see me. They take off from work to come see me. And so I have to show up, and I need to give them time, and I need to make sure that they feel listened to and partnered with. It shouldn't be, you're going to do this, 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 and this. It's going to be, well, here are the guidelines for how we treat this. Here are your options. Here's what I recommend. What do you think? But if you have not gotten that, and the doctor's on the way out the door, can you pause for a minute? Or can you pause from your notes if they're typing and they're typing in their note? Because we have to finish our charts before the end of an office visit sometimes. And I remember a woman came to see me. She said, I never felt so disrespected at XYZ hospital. The doctor never even looked at me. And I said, were they typing? She said, yes. I said, well, I understand that. What you didn't understand was that they had to finish that note, and they were trying to capture what you said. So they're typing and looking at the thing, but it doesn't excuse it. But you can ask, hey, could you pause a second from the notes? Can I have a minute? Can you explain to me what I should expect between now and then? What I'm hearing you say is, or, I might need a little more time. I might have more questions. Can we schedule a follow-up? Can I have a virtual appointment? Can I follow up with your nurse? Can you send your nurse in and let me ask her some questions and go over a few things before I leave? The other thing is that if you are facing a cancer diagnosis, you should not be alone. And we don't like to talk about it. I get it. But you should have somebody in that office who can take notes for you, who can hear what you can't, because once a person hears the words, you have cancer, it's really hard to hear anything else. And so if you are the advocate, you got to be the person who can say, wait, doc, let me catch. So how do you spell that? You can't be falling apart over in the corner. You got to take the notes down. You have to be the eyes and the ears. And we need to bring folks into the room who can be advocates with us. And if they cannot be there in person, the beauty of telemedicine and of all this technology is that they can be on Zoom, they can be on FaceTime, whatever mechanism you have for inviting your family member to be a part of, or your advocate, your church member, whomever. Somebody should be there with you because they can hear things that you might not be able to. Should we look at this further? How can we be sure? When are we following this up? And I recognize that when you're sitting in a gown with no clothes on, you don't feel empowered. And so, you can go to the website for this is www.morethanjustwords.us, morethanjustwords.us. And you can actually print this out. This is a PDF file, and you can take it with you so that you have something written down so you can feel a bit more empowered. Because when you're in that moment, you don't always feel like you can remember all these things. You may feel like the doctor doesn't want me to ask questions. That might not be the doctor for you. You should always be able to ask your doctor questions. And when you say, hey, listen, what would you do if I were your family member? If they don't look you in the eye and say, you know what, if you were my wife, I would blah, 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 get a second opinion. And it's always okay to get a second opinion anyway. No doctor should ever make you feel guilty because of that. Now, I want to switch gears for like 5 more minutes and talk about triple negative breast cancer, because as we talk about bias in healthcare, bias is real. And it exists not just because of racism, but because of structural inequities that have existed and persisted since before we all got here, right? Our healthcare system in this country. And when I talk to students about this, I remind them the first interaction that our people had with physicians was that the physicians were on slave ships to keep us alive long enough to sell at the block. So what do you think people would think and feel about a doctor? And can you understand why? And how can we bridge that gap? How can we build trust? Because things like triple negative breast cancer show the inequity between how Black women are treated, between what the death rates, the mortality, the incidence. This is a key example of a health disparity or an inequity that leads to disparity. So triple negative breast cancer is a more aggressive type of breast cancer. And the triple negative part of it is that on a cancer cell, there are 3 little areas or stations or receptors. They're like toll booths on the PA Turnpike. You know how you go through the turnpike and there's the booths, lane 1, 2, and 3. Those are 3 receptors on a cancer cell. And when you have them, it tells us what's driving your cancer to grow. So one of the receptors is for estrogen. So if you got the toll booth for estrogen, then I know you're using dollars. Dollars is estrogen. And then we can offer you a pill to block your estrogen so you don't make new cancers grow. When you have triple negative breast cancer, you don't have any of those toll booths. You're in the easy pass lane and you're not using dollars. You're not using estrogen, so can't block your estrogen. So those are women who have to, more often than not, get more aggressive treatment for their whole body, like chemotherapy, because we don't know what's driving their cancers. So the facts are this: it's only 10 to 20% of cancers, but it's probably the most aggressive subtype. Women who have the BRCA mutations, men as well, are at increased risk of developing triple negative breast cancer. It's more likely to progress, more likely to metastasize or spread beyond the breast and the armpit. Patients have a high rate of recurrence. The rate of mortality, unfortunately, is higher, and they're usually diagnosed a lot later. How does that relate to Black women? Well, here it is. Black women are 3 times as likely to be diagnosed with this more aggressive kind. Our tumors are usually larger, even when you normalize for people who have access to insurance and people who don't. Somehow, our tumors are bigger, they're more aggressive. Younger women, more common in young women under the age of 40, are nearly twice as likely to be diagnosed with triple negative breast cancer. Hispanic women, our brown sisters, more often diagnosed with triple negative and a higher rate of mortality. So why is this, right? It's multifactorial. You'll hear on a lot of multimedia that it has to do with socioeconomic status and access. And I think that is part of it. COVID has not helped it any. We told women, don't go to the hospital, right? Don't get your mammogram, put it off. And guess what people did? They did what we told them. They put it off. They didn't get their mammograms, but they also didn't get Diagnostic mammograms if they had symptoms. They felt a mass. They had nipple discharge. They too didn't go. And those are people who should have gone. And now we're seeing women who are diagnosed with later stage cancers because they waited. And there was a really big miscommunication, I think, regarding what is screening and what is diagnostic. Screening is when you're not looking for anything, it's your annual. Diagnostic is when you're checking for something. You feel something, you have a symptom. Those are people who should be seen immediately. So for those of us who are already not going consistently, and then we waited, well, now we have a higher risk. We have higher breast density, so that puts us at increased risk. When you look at these numbers, right, 93% increased risk of death for people who are underinsured or uninsured. We're less likely to do more aggressive therapies like chemotherapy, radiation. And we don't have all of the reconstructive options sometimes because one, our doctors might not offer it to us, and two, our disease is more advanced, coming through the skin, into the armpit, into our chest wall. So we have a lot of work to do to overcome this disparity on all fronts. One, on the front of knowing yourself and knowing your body, knowing you're normal. Two, knowing your family history. You know that mom had breast cancer. Next question I'm going to ask you, do you know what kind? Was it triple negative? Because if it was, I need to check your genes to see if you inherited a mutation. Younger women should be screened earlier, and we're not doing that. That should be a recommendation, and that's something that we're lobbying for. It's something that you perhaps, if you are interested in advocacy and want to know where to get involved, that's an area we can get involved. Knowing your breast density, we're required by law to know how thick your breasts are. Okay. And when you get that letter, your letter is going to say the sensitivity of mammography for heterogeneously dense breasts or greater is diminished. And it'll say your breast density is category A, B, C, or D. Or it'll say category 1, 2, 3, 4. Or it'll give an actual percentage 0 to 25, 25 to 50, 50 to 75%, extremely dense breasts greater than 75%. So when you know your density, then you can know what types of screening you should be getting. So the things are to know your normal, know your history, know your risk factors, okay, so that you can feel empowered. And it's a good time to, this is the last slide I have, to talk about really what the definition of health is. Because when you partner with your doctor, when you go to that doctor, our job is not to just fix the reason you came in. I got the sniffles, or I feel a lump. Our job is to really try to help to restore health. And health is a complete physical, mental, social well being, not just the absence of disease. And yeah, primarily, my job is to get rid of the disease. But I tell my patients, I do them no service by cutting out a tumor if we haven't addressed all the reasons why it happened, the risk factors for it happening again, and the mind, body, and spirit that all contributes to wellness or to disease. So when you talk to your doctor, you want to talk about and get a feel for that doctor's philosophy about your overall health, especially a primary care doctor, because that is what instills trust. When a doctor recognizes your point of view, your cultural beliefs, your spiritual beliefs, when they honor your faith, that builds trust. And it's super important for our community. And so, with that, I will say I'll take questions. You can find me at gvh.org. I'm Dr. Monique Gary on all social media outlets. And I will see you all on Saturday at the health fair. I don't know how to stop sharing my screen. Am I still sharing? I can't hear you at all. We can see your slide. Okay, I'd like to stop sharing. Hold on one second. Oh, I hid the little thing. There we go. All right, stop sharing. Now I can't hear you at all. Are you on mute?
There we go. Can you hear
Hey.
me now? All righty. Okay. That was great. All right. So, just a few things. I know that you kind of like went over your key points at the end, but there's a few things in there that I hadn't even thought about as far as like leveraging telehealth
Yes.
and asking for a follow-up appointment.
Yep.
Yeah, telehealth. So I don't know how often that happens, with you, or if you have experience with that,
Hmm.
but I've never had a physician offer that as an option.
Hmm.
Um, so just wondering, I know you're not an insurance, specialist,
Sure.
but just wondering, is that something that someone could ask for and expect that the doctor is going to make the appointment so that they can
Hmm.
access that doctor through telehealth?
So yes, there's a couple ways that can happen. And really, really what happened was COVID happened. And all of a sudden we couldn't go into a lot of our offices and practices. And so we would continue to see patients virtually. Now it's really hard to do a breast exam virtually, but
Yeah.
I can say, hey, how you doing on that medication? Or,
Mhm.
you got your MRI, things look good. How are you feeling about, let's talk about your surgery. We can have a conversation that's even better sometimes virtually, and it has enabled us to be able to see patients from all over. So I've seen patients from Texas and California and Erie, Pennsylvania, because what you do is you can call that office. Let's say you're at an office and you want to see your doctor again in a telehealth appointment. You can ask that nurse before you leave. Usually there's a nurse who's a navigator, especially if you have cancer. That nurse is a hand holder. If it's just a PCP visit or gynecologist, when you go to the nursing station, that medical assistant who's helping make appointments say, does this doctor do virtual appointments? Can I do a telehealth? Or you can ask the doctor too. Do you do virtual consults? Can we follow up by phone or virtually on computer?
Mhm.
And 90% of us, at least, are doing some form of telemedicine, in follow ups, especially, or by phone. That phone can absolutely happen. And that can be a conversation where if you're home, you have your relatives, you can put it on speakerphone and you can get questions answered that way. So it's something you ask for, because most appointments, offices will try to make them in person because they think that's what people want. And that's our pattern. But
Mhm.
virtual is possible.
Okay. Thank
Hmm.
thank you for that. And the last piece that is resonating with me is, I know we have our parents, and they start sharing information about cousin Johnny. Remember him from back whatever? Like, no, I really don't. And you kind of
Right.
tune out. I never met them, but now it's like, wait a minute, having that conversation, like, oh, wait a minute, what happened to cousin Johnny? Can you
Yeah.
tell me more? Never even thought about it, but that's amazing to, well, now I will start listening more when she calls to have those conversations, but that's hugely
Yeah.
important.
Yeah,
Oh my
it
goodness.
is. My experience has been, I'll tell you, my mother died of ovarian cancer. She was 29 years old. And my family, it was a horrible thing for this young woman with two kids to die in this family. And so nobody talked about it. Nobody wanted to mention it. It was like the thing that happened in the family that just, we don't talk about that.
Mhm.
But don't you think that I need to know, as her daughter, that she died of a rare cancer? Less than 1% of the population has it, and I could have a mutation. My grandmother had breast cancer twice. That
Mhm.
means I'm at the intersection of high risk, right?
Mhm.
Breast
Mhm.
cancer, ovarian cancer, I should get genetic testing. But we don't like to talk about those things. Or it's, we're not really sure, it's something down there, or she went to the hospital and didn't come out, or I'm not really sure because of, or don't ask me about that. Don't ask me my business. That's my
Mhm.
business.
Yeah.
Hmm. And so you got to be a little crafty with our seniors. And so that's when it kind of, you guys are sitting down and, I I don't know if anybody snaps beans anymore, but if you're doing some family
We
something,
do.
I'm so old, right? Oh, you do, yay! And so those are the times when you can be like, Nana, I've been really getting into my health and wanting to make sure that I'm getting the right screening and stuff. Can you talk a little bit about the health family history? Any cancers I should know about, in the family? Or if that doesn't work and she had something, and say, you know what, I always admire your faith. And I've been trying to build my faith too. Tell me about some things that God brought you through, and just leave it there. Let me tell you, he brought you through this, he brought me through that. You get the whole story when you ask that question about your faith, and how that faith has gotten you through some things. So there's some crafty ways that we got to talk,
Yeah,
talk to our families.
that's a whole session. How to start those conversations, because it's very hard, especially within our community. You just have that secrecy, and
Yeah.
it's a whole nother dynamic to that interaction of what's considered,
Mhm.
what should everyone know about, what's my personal business.
Yeah.
and not understanding like how that affects
Mhm.
the next generation and next generation. So
It's true.
yes, very powerful stuff. I love it
Wow.
all. Um, I've been saying that all day long. It's like every session, I'm like, oh my gosh, that was incredible. We we're recording this, as I told everyone. If you want to invite someone to watch this later, we have recorded it. We're going to upload it so you can watch it later. And like a couple of the other ones, I think we're going to probably chop this one up so
Mhm.
folks can grab what they need, and you can watch it at your leisure. So that will be uploaded on our new YouTube channel next week, Disrupting Build Up.
Wow.
And I want to encourage everyone to please visit the website that Dr. Gary offered, www.morethanjustwords.us. Thank you very much for that resource.
Mhm.
And
Are you linked in with social media like Facebook? Will this play there, or can people link and share it on Facebook?
Yes, right now it's streaming to a few of our partner Facebook pages. Like there's a couple local NAACP pages that it's streaming to right now, and I don't have the whole list in front of me, but
Mhm.
it is out there on those pages, and so I can share that with you as well. They can get that now. Okay, great. All right. So be sure to tag Dr. Gary. She is very much on social media, so she will respond back. And I will just preface this like I have been with our other physician. She is a physician, but not your physician. So be sure to just, take, all the information that she has so that you are more empowered when you go and engage with your physician. Or maybe you might realize, oh, I need to make some changes. And I was about to end, but I think this is important too. We had a session last year and we had this physician on, and she's going through this list of how your visits should go. And I'm like, my visits have never gone like that.
Yeah.
I was like, is this what doctors are supposed to do? I was like, you can ask questions and they don't get irritated. You can, bring in all this other information. They're like, yes, please, we love it. And I was like,
Mhm.
no, I haven't had that experience. So just understanding what we should expect, but what we have learned to accept is different than what we should actually be receiving when we go to the doctor's office. So I think that's just like very powerful for a patient, but a Black patient as well, even more so. So again, thank you. We need to keep lifting up this information. Thank you for mentioning the event this weekend. For those of you who are in the southeastern region, this is a statewide conference, and different organizations are having their own in-person events across the state. They're doing some in Pittsburgh and Westmoreland and Lackawanna. And here out in Montgomery County, we're having a health fair. So you can come out and see us, 1818 Beach Avenue. And we actually will have an Ask Dr. Mo piece. So you will be able to actually see Dr. Gary in person and engage with her at that event. It is from 12 until 4 p.m. this Saturday. Again, that's 1818 Beach Avenue, Elkins Park. Thank you again, Dr. Gary. I appreciate you, and thank you for your time. And
Thank you for having me. I will just say that if you have health questions that you want answered on Saturday, you can put them on my social media. I'm on Instagram at Dr. Monique Gary, and we can preload those questions. And when we see you or when you come out, we can get those things answered because, it's important to have access to doctors you can trust who give good information, who are going to answer those questions. And everybody's got something that they've been wanting to know about cancer in particular, but really about anything. If you have health questions, we're going to get into it every hour, I think,
yes,
at this fair.
yes.
So we want to know.
All right. Thank you for everything in advance.
Thank
All
you.
right. So to all the attendees out there, we will be starting. Actually, our comedy show starts in about 5 minutes. So our Laughter as Medicine comedy show goes from 5 o'clock until 5:30, and then our next two sessions are moderated sessions: the myths and majesty of maternal health, We'll be talking about male doulas and the dynamic between the man and the woman, and that maternal health goes beyond the woman. And we have to start including men in that conversation. And what does that mean? And what is male nesting? And all those things that we have never even thought about before. So it should be an interesting conversation. And we end the night with Andrea Lawful Sanders and many therapists and a physician, and you can ask those questions that you've been too embarrassed to ask. A candid conversation about libido, contraception, and other things. So be sure to join us tonight, and that will close us out for Women's Wellness Day. All right. Thank you all for attending. See you at the next session. Bye-bye.